Hello and welcome to CalHIPSO's monthly webinar series. My name is Deanne McCallan. Many of you know me from the past number of years as CalHIPSO's program director. All attendees are currently muted. However, we hope to be able to open the platform for discussion during the presentation, and if not during, then at the end. In the meanwhile, should you have any questions, please enter them in the chat box and we'll be monitoring that as best we can. Today's webinar is being recorded, and both the slide deck and the recording will be available on our website, www.calhipso.org soon. For today's webinar, we are joined by MedEx's CEO, Claudia Williams. What an opportune moment during this global pandemic to hear directly from Claudia on recent CMS and ONC interoperability rulemakings, as well as how health information exchange is and will play a part in our nation's response to COVID-19. Before I pass the controls over to Claudia, I have just a couple slides to cover. I looked at the registration folks who had registered for this webinar. I'm pretty sure most of you know CalHIPSO, so I'm not going to read any of the details here. And these are just some graphics of today's topics. So definitely health information exchange, interoperability. We might touch upon telehealth. That's definitely critical, trending right now with the stay-at-home orders in California. And hopefully everybody is doing well during these trying times. Some updates from CalHIPSO. CalHIPSO has recently transitioned. Congratulations and good luck to David Ford. He is now the Vice President of Health Information Technology with the California Medical Association, and I've included David's new email address here in case people are looking for David. The CalHIPSO May 7th conference has been canceled, of course, due to the coronavirus and the stay-at-home orders. And please stay tuned with CalHIPSO messaging as we pivot to building the interoperability agenda that was the plan for our May 7th conference. CalHIPSO is in the final months of the California Technical Assistance Program, where we are still helping eligible professionals and practices and community health centers with the Medicaid Promoting Interoperability, also known as Meaningful Use, for program years 2019 and 2020. So if anybody listening today knows somebody who still needs assistance with that, please have them reach out to us. And if it's not CalHIPSO, I can help connect with the other 3 CTAP contractors in the state. We are Practice Transformation Specialist Field Team for the Aledade Medicare Shared Saving Program, ACO, Accountable Care Organization. Have been really busy working with Aledade and the California practices that are on board for 2020 in response to the COVID crisis and getting telehealth up and running for a lot of those practices. And we're also here to help spread the word about the Department of Healthcare Services CalHOP, California Health Information Exchange Onboarding Program. So a couple weeks ago, DHCS was able to share information with folks in the state through their website that the program CalHOP has been approved by CMS. So they're still working on the launch of the program. As recent as March 20th, DHCS published a list of health information exchange organizations who have met qualification requirements for the CalHOP program and are eligible for participation. So that list is on there. And that one of the 5 folks on that list that's posted today is MedEx. And with that, I will pass off to Claudia.
Thank you. We are excited to be sharing some updates with you guys and also some recent work that we've been doing on COVID-19. So the first half of the presentation will be a fairly high-level summary of recent regulations that were finalized by CMS and ONC. And if it hadn't been for this pandemic, I expect that would be a focus of a lot of our energy in the last month. But with the emergence of this global crisis, I think we, along with many others, have really been focusing our attention there. So the second half of the presentation, I'll share with you some of the things that MedEx is working on and doing in ways that we're hoping we can support the frontline providers as they help us stay safe and heal our loved ones at this critical time. I'm trying to advance. I'm not, did you guys hand it to me?
Yes, so you should have keyboard and mouse control. It might take just a second to kick in there.
Okay, let me try again.
Possibly try moving the mouse around first.
Okay, so I'm sure many of you have similar, and that's a super unattractive picture, I think, of myself, but we are all in these video conferences every day doing our work. This is a picture from the daily stand-up I have with the team at MedEx that's focused on the COVID response. So I just want to know, like, we extend our appreciation and thanks to all of you that are keeping the fires of your work burning, but in a different way. So just a little teeny bit of background about Manifest MedEx before we dig in. We are a health information sharing network serving California. We currently share records for about 21 million people. We combine both clinical data from practices and hospitals and claims data from the health plans who participate. Those participants include about 600 organizations, which including 100 hospitals and 7 plans. So we are a pretty unique HIE organization in that we're really the bridge, bringing together both claims and clinical data and making it available at the front lines of care and also for proactive population-based health. So we, with great interest, have been reviewing and summarizing the regulations. Again, I'll keep this pretty high level. This, many of you probably, like us, have been reading them, but here are some of the things that we've been thinking about and focusing on as we review those regulations. The 3 components that I'll focus on in this presentation are ONC's information blocking penalties, and the CMS's rule, which lays out new API requirements for health plans and notification requirements for hospitals. So information blocking, and the way I think about this is that many existing privacy regulations, including HIPAA, basically permit information sharing. So they say you are allowed to share information in the following ways, but they don't require it. And what these rules do at their most essential core is they flip the switch from permitted, from an organization being permitted to share for purposes like treatment, payment, and operations, to now being required to share unless that sharing is covered by one of the exceptions. This is a really big switch because we're all accustomed to laying out lots of use cases and kind of edge cases for when information can and can't be shared. And honestly, I think we're all going to have to go back to the drawing board and look at our current contracts and our current patterns and be sure that we're not violating information blocking through those contracts. So who's subject to this? It would be a health information network or exchange similar to Manifest MedEx, healthcare providers, and health IT developers. So a very broad spectrum of organizations are covered by these rules. There are 7 exceptions or safe harbors. I won't be going into the detail around those. Things like if it could cause patient harm, or if it would violate privacy in some manner. But note that participation in TEFCA is not one of the safe harbors. So everyone was looking to these rules to create a strong link between information blocking and TEFCA. That does not exist in these rules. It's possible that CMS or ONC will go back later and create that stronger link, but I think part of what's going on is wanting to see if TEFCA takes hold and gets broadly adopted before other regulations or penalties will link to those regulations. you know, for many of us, we have business associate agreements, and those business associate agreements might have specific restrictions on information sharing. The rules don't say that those are no longer allowed. I mean, and they're required by HIPAA, but they do say that you can't use them to discriminate. So for instance, if I had an agreement with one provider or hospital that said information could only be used in this way, but other agreements said something else, that would no longer be permissible. Now note that the information blocking rules take effect 6 months after publication, but the rules have not yet been officially registered on the Federal Register. So that timetable will only start, that clock only starts ticking when those are registered. So that may be one of the ways in which the federal government is waiting to see or creating a delay for these rules. A lot of people expect that the COVID-19 pandemic may cause the government to delay. So one of the ways they may be doing that is by not yet registering the rules in the Federal Register. Also, if you remember, the information blocking rules applied to this very broad concept of electronic health information, but that requirement to share EHI is not going to go into effect till 2022. Before that time, a more limited set of data will be required to be shared, and they've pointed to the US CDI as the data set that needs to be shared more immediately. And we'll have time at the end for questions or comments or additional points that other people on the phone might be able to share. We're less focused at MX on the certification part of this rule, but in short, in the certification rules, the US CDI replaces the common clinical data set as this kind of concept of a collective of data that needs to be shared in a variety of ways. The US clinical data set was expanded, the US CDI was expanded to include clinical notes, provenance, and this concept of EHI export, being able to take all the electronic data and export it. And also the certification rules are now going to be expanded to include the FHIR Release 4 for APIs, and we'll talk more about that later. So the parallel regulation that was finalized before the HIMSS time would have been include the requirement that if you remember, CMS for some time now has been sharing claims data from Medicare with app developers that patients might want to use through what's called Blue Button 2.0. And those same requirements are now going to get extended to any plan that has a federal connection. So that would be MA plans, Medicare Advantage, Medicaid, and CHIP agencies, as well as plans, and plans that operate on the federal exchange, the QHP plans. And so those plans are going to now be required to share information through a FHIR version 4 API that would include claims, explanation of benefit, cost sharing, and any clinical data that the plan has. And the timeline, the amount of time that can elapse between receiving the data and sending it is very short, only 24 hours. Plans need to implement this requirement by January 2021, and I will note that that is a fixed date in the regulation. It is not a date that's triggered by the release on the Federal Register. So unless they go in and make a change to that date will stand firm, even if the regulations are not posted to the Federal Register till later. So the whole concept here is that a member, an enrollee of any of these programs would be able to, with using these simple FHIR version 4 API and OAuth, be able to connect their own claims data to an app of their own choosing. Many plans and other stakeholders in the community ask for there to be additional security and privacy requirements on those app developers. But CMS really demurred and said, listen, that is not our jurisdiction, and HIPAA does not cover those app developers. So you may not restrict access of the API to those app developers unless there's a security problem created by your own onto your own system. You may, however, ask those app developers to attest to the policies and procedures that they have, but you can't limit access to the API to only those app developers that you think meet some particular benchmark. So really, they did not respond to the widespread desire to have additional privacy, and I think for good reason, because as you know, HIPAA does not apply to apps and tools that patients choose on their own, and there really isn't any jurisdiction to extend HIPAA to those organizations. Additionally, it's of note that the regulations state that there will not be federal funding available to plans to implement these API requirements. Medicaid programs can request funding through the MMIS technology funding, but that funding cannot be extended to plans themselves. And so it's possible that states will expand allot some money through capitation, or they may not. So plans are really pretty much on their own to implement those API requirements. Another pretty substantial requirement that's built into these CMS regulations is that every hospital must send digital alerts to community providers using admit, discharge, or transfer data, ADT data. And this will become a condition of participation for both Medicare and Medicaid. That's the biggest hammer possible, right? It's not an incentive, it's not a penalty. It simply says if you don't meet this requirement, you don't get to participate in those payment programs. Those alerts need to be given for both emergency department visits and inpatient hospitalizations. They must include the name, the treating provider, and the sending institution's name as well. They can be sent directly or through a HIE like MX, and it must be implemented 6 months after the rule publication. So this is one of those requirements that will start, the clock will start ticking once the rules are up and on the Federal Register. So we know in California, there are a lot of hospitals that are not yet connecting ADTs to alerts for community providers. So there'll be a lot of work needed here in our home state to make sure every hospital can meet these requirements. Notably, the CalHOP funding, which provides milestone payments for data connections, is available to HIEs and hospitals who want to start connecting ADTs and making these alerts available. Other provisions, just to note, providers must list digital endpoints in the NPES. That's a directory that CMS maintains. The care coordination, meaning the requirement that there be exchange. Actually, I'm gonna have to double check this one because I see below that the care coordination piece was finalized. So I'm gonna have to double check that top one. And then CMS regulated payers must exchange patient clinical data at the patient's request when patients switch plans, and make an API available for the provider directory information. Oh, let's go to the top. I know what that was. So the CMS rule had provided a link to the concept of TEFCA by saying that plans must participate in a trusted exchange network. So I'm sorry, I didn't correctly label that one. And that was not finalized. So once again, CMS demurred on an opportunity to link these rules to TEFCA and is really holding off to see what the eventual implementation of TEFCA may be. Okay, that's it for the regulatory summary. We'll take questions at the end, but I wanted to take a few minutes to talk about some of the things that Manifest MedEx is involved with in terms of really giving providers and public health the tools they need to be effective in this critical and hard time of the COVID-19 response. So first, maybe some context. I mean, like you, we've been in conversations with health plans, with labs, with hospitals, with public health about what kinds of patterns are we seeing on the ground today as the pandemic really creates a lot of changes across healthcare. So the first one is that I think overnight we saw the liberalization of rules around telehealth, and also that, you know, many providers are asking patients not to come in to in-person physical services unless they absolutely need to. So we're going to see a dramatic uptick in telehealth visits, and that couldn't come sooner because ambulatory providers are also seeing a dramatic decrease in the billing they're able to do for in-person care. So many are laying providers and nurses off and front office staff off. And so the sooner that we can help them get going with telehealth, the more we can help them preserve their practices and have some financial footing that will allow them to weather this period and stay financially viable for the future. So one is just like a big uptick in telehealth and a dramatic need to support practices, especially smaller ones, so that they can be financially viable over the next few months. Also, there are requirements that providers report any COVID positive cases to local as well as state public health, and that populates a registry called CalReady at the state level. But I will say that those results are not available to providers on the front line unless they were the ordering provider. So if you're an ED doc, if you're an ambulance driver, if you are a PCP, you are not going to get proactively notified when one of your patients tests positive. And I think that's a really big issue and a really big challenge. And there's potentially opportunity to see if we could pursue some liberalization of those public health constraints. But for right now, that's the situation. And also, I think we're seeing a need across the state for real-time insights about what are the kind of volumes we're seeing in hospitals, what are the volumes of ED visits, what are the volumes of admits and the censuses, so we can identify hotspots as certain areas may see an increase in cases. So this is just sort of global context for some of the things that MX and other people are working on. So just quickly, MX offers a suite of services that bring together claims and clinical records. MX Notify, those are the real-time alerts that take ADT data and turn them into an alert to a PCP when their patients are seen in the hospital. Access are our longitudinal records that bring together claims and clinical data, so you could log in and see a patient's record for an individual patient. And last, Analyze is our pop health dashboard that brings together claims and clinical data and allows a practice, an IPA, or a health plan to filter to look only at certain patients. And we'll talk in a minute about how that's really useful in the COVID response. So we've really been looking at these tools and identifying ways in which they can be most helpful to providers and IPAs and others on the ground. So in the case of MX Notify, one of the interesting use cases, especially as cases increase, is the ability to turn those positive cases into a panel so that I, as a PCP, or I, as a hospital or an IPA, would be notified in real time if any of those positive cases actually shows up at the ED department or gets admitted. We are seeing we'll be increasingly see positive cases who are not folks that are getting admitted, but are returning home to monitor in place. And so being able to know when that patient got sicker and turned up at the ED or even was admitted could be incredibly helpful. In the case of MX Access, this is where a provider would be able to see a positive COVID case from any of the labs that are feeding data into MX. So we're connected to LabCorp, Quest, Public Health Labs, and hospital lab data feeds. So that would allow a provider to see if there's a positive result coming from any of those sites, but also to better understand an individual's risk, so that you can identify if that person might be at increased risk because of having diabetes or asthma for complications from COVID. So that individual record can be really helpful in this circumstance to better understand that individual's particular circumstances. Now, Analyze, this is a really interesting example, and we've already been helping ACOs and IPAs and health plans use Analyze to identify patients that might be at greater risk. So let's say you are an IPA or you're a practice, you have all of these tools turned on, and you now want to start billing for telehealth. Remember, you can bill at the same rate you'd be paid for an in-person visit, but you want to focus first on the patients at the greatest risk. So what you could do is use Analyze to basically go through all the claims and clinical data for your patients and identify those at risk of diabetes, who have diabetes or asthma or CVD, for whom the complications from COVID-19 will be particularly great, or that might need some help managing that chronic condition. And that will give you a list of patients, and you can start your telehealth visits only with those individual patients. So here's just a screenshot of what that screening process looks like. And the practices using our tools can screen for whatever, we have some kind of suggestions for how to use the screening tools to filter to a particular list of patients. And then that basically gives you your call list of people to start with as you're starting to do telehealth. Okay, so that is an example of all of the things that we're doing with current tools to serve our providers as they're trying to adjust to the current circumstances. But the data that MX is pulling together is also extraordinarily useful to inform both local and state level response efforts. So in Riverside County, we are working with the COVID Response Command Center, and we are trying to take all of our lab results, and particularly the COVID-19 lab results, and turn them into a county level dashboard showing where are positive cases turning up, what are the demographics of those cases, what is the day-to-day trend in the number of tests, the number of those that are positive, and what is the disposition of those positive cases in terms of people who are at home, in the hospital, or who might have been discharged due to mortality. And so currently we are getting lab results from hospitals through their ORU lab feeds, from county public health, and also from LabCorp and Quest. And we're engaged in quite a bit of effort at the county level to make sure that we're getting all of those results in. In other counties where we don't have as good of a coverage, we will still be able to get interesting and important insights, but not at the level of spread that we're seeing in those areas like in Riverside and San Bernardino, where we have almost all of the hospitals participating. Also, we are taking, so we have 100 hospitals that participate with MX. About 80 of those are currently signed up and sending us ADT messages. And we're producing, daily producing basically kind of a census or a utilization report that looks at all of those hospitals. What are their daily counts of ED visits? What are the daily counts of ED visits with influenza-like illness, which will be like the fever and flu-like symptoms, whether or not those are diagnosed as COVID? What are the admits we're seeing every single day? And what is the census we're seeing every single day based on those ADT feeds? And then we're sharing those with county as well as state level public health and response teams, because this kind of data is of critical importance to folks that are interested in hotspotting and identifying where issues might be emerging. So we've learned a lot in the past week as we, over the weekend and throughout this week have been talking to people on the ground. But here's some of the questions that we still have. First of all, the workflow for testing individuals is quite unique, but what we're discovering is that in most regions today, there's still only a very small handful of organizations that are actually running tests. So you might have stood up a specimen collection drive-through center, but in the case of Riverside County, there are only 4 organizations that are actually running those tests: LabCorp, Quest, County Public Health, and Kaiser Permanente. And so by making sure that we can get the lab results even from just those few, we'll be able to show up all of those results for the whole county. But as more hospitals are doing their own testing, as some of these bedside options become available, we expect more and more of the testing will be done locally by the hospitals. So those hospital data feeds, the lab data feeds, will be critically important and of even more importance as this pandemic progresses. So one question is just like, are we getting all the data we want? How do we make sure we're getting all the data we want? We did ask LabCorp and Quest, the county public health officer asked them to send us all the lab results, and they declined. They said, we're already sending them to public health and we don't want to send them anywhere else. So we're working through that process with them. In the case of Colorado, the governor's team may actually issue an executive order requiring them to share those results with the HIEs, but we're monitoring that and trying to make sure that we get as many of those results as possible from LabCorp and Quest. Second big question is, what data can be pulled from ADTs? We get these ADTs from hospitals. Can we use those to track ICUs? Do we have any insights about ventilator use? And I would say for right now, we're sticking to just overall admissions because we're getting pretty spotty ICU data. And also part of the problem is as hospitals get more and more cases, basically all of their beds are going to turn into ICU beds. So we're kind of monitoring the situation to see what we can say, but it may not be that there's a lot of value in trying to quickly spin something up with on ICU, if in fact over time in hotspot areas, pretty much that distinction between a med-surg bed and an ICU bed may not persist. Last, I think on this page, CalReady, the state operates under a code that requires providers to report lab results to public health, both local and to the state. But those entities do not have, at least they haven't interpreted, they don't think they have permission to share those results back with providers. So that means an ED department, an emergency responder, a PCP, a hospitalist won't know that that patient was tested positive. So we're reaching out to CDPH to see if there has been any change in the interpretation of that code of conduct. Code of regulations. In other states, we are seeing emergency orders from governors that actually that say in this time and given the importance of sharing those results, those kind of confidentiality rules will not apply to COVID-19. So what we're doing right now is just trying to better understand what the policies are and explore whether it might make sense to advocate for some kind of change to those policies. So looking forward for MX, one is we're looking at a couple of new functions. One is pushing alerts of COVID-19 results instead of just having them available in our patient record. What can we do around ICU with all the caveats I already mentioned? Second, we're looking to really make sure that we are getting as many of those lab and ADT results as we possibly can. And we're really excited to be approved as one of the CalHOP organizations, because that will make resources available to HIEs and hospitals who can quickly get those ADT and lab data feeds going. And we are particularly focused on the many, many hospitals across the state that are not yet sharing an ADT or an ORU data feed with an HIE. Policy questions. We have this question around whether CalReady results can be shared with providers. And then part of the stimulus bill that was passed just now nationally changes the 42 CFR Part 2 data sharing provisions to allow for a one-time consent, and then those data would subsequently fall under HIPAA rules. But we have state level legal restrictions on those data that would need to be quickly changed so that our state rules could align with the federal rules. Also, we want to make sure that California can benefit from all the available federal resources, the $500 million that was in the stimulus for public health surveillance, emergency requests that can be made for Medicaid MMIS funding, And also there's movement afoot among other HIEs in other states to extend the deadlines for both high-tech 90/10 funding, which is paying for high-tech, for CalHub funding, as well as the Promise Act, which makes opioid-related 90/10 funding available to states. So lots of stuff going on in that front. I think that is it from us. We would welcome comments, questions, additional ideas, anything that you think contributes to the conversation. And maybe I'll ask Lauren or Deanne, if I don't know if you want to moderate the discussion or how you want to run that.
Yeah, so we did have one question come in during your presentation around 12:30, and the question was, how about patients who get discharged to SNFs, home health, and other facilities? Often that's where the disconnect happens once the patient leaves ED.
Yeah, I assume this is talking about the COVID-19 or about the hospital alerts? Yeah, so it's a really good point. I think there's actually critical value for connections to SNFs and nursing homes at both ends, both in terms of people being admitted and being discharged. And those providers would fall under the CalHub resources. So I think that's another area that might really benefit from prioritization is HIEs making data connections to those providers. They didn't benefit from participation in meaningful use. So what you see is some of those organizations have kind of interoperably EHRs and others don't. So I think it can be difficult to connect to those organizations, but even if they don't have EHRs, they can still generate a panel on our products. So they could still tell us who all of their patients are, and that if they do that, they would themselves get alerts when those patients get discharged. So I think information in from those entities can be challenging given the kind of fragmentation of the EHR landscape, but they can be important users of HIE information as well.
Thank you. And then as far as questions that we had sent in, that's all we had. I don't know, Deanne, did we want to try opening the line to attendees to see if anyone had any further questions?
Yeah, and this is Deanne. I have a question to start it off. Back on slide 16, under the regulations, that I kind of like the nomiker, the HIMSS Week regulations that dropped. It said that CMS, that payers are required to have a provider directory. So do you know in your read of the regulations, Claudia, whether CMS is holding themselves to that? Because that's one of the things people have been asking for years is provider directory. So CMS themselves are a payer. So
I don't know. That's a good question. I mean, obviously they have NPES, which I think could be considered a provider directory. But I don't know whether, so I guess what your question would be, CMS fee for service, will they also need to release an API? Is that what your question is? And I can certainly follow up on that. I don't remember.
Yeah. And yeah, Lauren, let's try to open it up to see. And besides everything that Claudia covered, you know, for thinking the week that the rules dropped, the week of March 9th was starting the uptick of seeing the reality of COVID in California. So that week it was like, oh, I'll read the regs later. And there certainly has not been a moment since. So Claudia, I appreciate that you were able to summarize this without putting us to sleep either, because a lot of the times an overview of the rules can be a snoozer, and I thought it was pretty interesting. So it will open it up to everybody if that functionality works for us. And besides everything Claudia covered, is there anything anybody on this webinar has thought of that we could collectively do to help with a COVID response or with HIE and with potentially CalHub? Is there anything CalHIPSO, Manifest MedEx, if you have any ideas, like Claudia said, of things we might not have yet thought of, because I think there's still a lot of those ideas coming. So let's see, there's not a ton of people on the call, so if you want to try to speak up if you have any questions, and if not, then we'll move on.
So I have set it to unmute. I'm seeing one person raising their hand. I'm going to go ahead and select them. It looks like Daniela, if you had a question.
We can hear a little background, but we cannot hear Daniela. Hi, Daniela.
Okay, maybe there's an issue with the mic going on.
Can you hear me?
Yeah.
Oh, yes, we can hear you.
Yeah, it was not letting me unmute, so now it's good.
Okay, perfect. Sorry about that.
That's all right. So one of the challenges we see here in this community is that we unfortunately don't have a way to share data. I'm still working with Manifest to see how I can get on board as a single provider here. The challenge I see here is that all the providers are pretty much in silos. Even though we have IPAs, we have 2 hospitals, there's not much of communication from them. They're doing their own thing in terms of how they're dealing with patients, but we have no idea when our patients are showing up there. We've been sending our patients for tests outside. Quest takes 4 or 5 days to get back with results, etc. I know this is probably the best time for everybody to be on Manifest or some kind of an HIE where we are aware of where our patients are and what their results are. In terms of the timing, since we are not there, are you able to do anything or suggest anything where there is a shared
I'm sorry, I just lost the question. Can you repeat it? We lost the last phrase.
Yeah, it's for some reason system is unmuting itself. Can you hear me now?
Yeah.
Okay. Short of being on the HIE right now.
And we heard most of it.
Okay.
Yeah.
Is there any option for us to actually share information with the local community health systems, the county, or the hospitals?
I hate to say, I mean, the best thing, so MedEx services are free for doctors and for any ambulatory practices, and the data sharing requirements are pretty nominal and doable. So I don't think there's anything standing in the way, unless there's something I don't understand, of an ambulatory practice just joining MedEx.
No, I believe that. Actually, I'm in the process of signing up myself, but the challenge is that, in this tough time, it'll probably take few weeks to get people lined up and signing up, etc. But I think the need is now, right? So outside of HIE, have you seen anything in the market where communities are still able to share, the health systems and providers are able to still share and know where their patients are?
Personally, I haven't. I think, our process is extremely streamlined, so I haven't seen anything that's faster than that.
Okay.
Honestly.
All right.
And, one of the things that's pretty unique one of the interesting things is that we have claims data for Anthem, Blue Shield, Inland Empire Health Plan. So even when not all the doctors in a given community are participating, you would still see their encounters through the claims data. A little bit delayed, but you'd still have a ton of data and background from those claims data. I do think this is the time for all of us to encourage and urge hospitals to send lab results and ADT data. If we don't get those lab results, we're never going to be able to communicate those positive cases to all the other doctors in the ecosystem. And as I said, that's not going to be available through public health. So I think those lab data feeds and getting hospitals up, and I know they're under a lot of a lot of stress right now, but that's going to mean they don't have to find other ways to fax those results to primary care. They can just rest assured that there'll be a way to get those results out to who needs it, right? So I think this is the time to lean on, frankly, folks, to participate. And, in LA County, the public health officer is requiring every health system to make a full-time person available to handle data reporting. And my point was like, if you could set up an ADT and an ORU, maybe that takes 20, 30 hours, and that saves you 160 hours per month of time that you're gonna have to devote. So I think there's, you know, if we can make a little investment at the front end, we can avoid a lot of pain at the back.
Great, I'm ready.
Okay, other questions?
No, I
Anything
didn't.
in the chat?
Right now, I'm not seeing any other questions coming in. You do have the ability to unmute yourselves if you're using cell phone and you currently have yourself muted. You can unmute using your cell phone if you have any questions.
Will this presentation be available, the recorded version?
Yes, yes. So the recording of this presentation and the slide deck itself will be available. I'll be sending out a follow-up email probably sometime tomorrow afternoon with both of those things.
Great, thank you.
You're welcome.
All right. Well, it's just a moment past 12:45. So with that, we can give everybody back almost 15 minutes. Claudia, I'm sure you have, I can see that you guys have been quite busy on not just the regulations, but having good data and helping out at the very least down in Riverside County, which is a good template for other counties. And hopefully California continues to stay sheltered in place so that we can keep these numbers relatively, well, keep that curve flat. And appreciate your time.
Thank you.
Thank you.
Thanks for the opportunity.
Thank you so much.
Thanks, everyone. Thank you, Lauren.